So for those of you who don't know, St Vincent's is located on the fringe of the CBD here in Melbourne, and it's a tertiary teaching hospital. We have multiple campuses. However, the Fitzroy campus is the main facility where we deliver acute care. And at St Vincent's, at all facilities, we have close to approximately about 1,000 people die each year. So in Australia, over 50% of people die in acute hospitals. However, this isn't always their preference, and they would prefer to die at home. Skilled and compassionate care of the dying is required to deliver optimal end-of-life care. However, delivering this optimal end-of-life care is often challenging due to a couple of factors. The first being healthcare professionals have limited training in end-of-life care, and in the past, with serious illnesses, infections or injuries, this often led to a fairly rapid death. However, due to advances in medical technologies and interventions and improvements in public health, we see people living with chronic illnesses and disabilities and have significantly increased life expectancies. And all these advancements have also impacted on the dying process and experience. Communication about end-of-life care is an essential element for high-quality care and allowing patients to make informed decisions and to express their values and how these relate to their healthcare choices. Hence, it's really important that clinicians are equipped with adequate knowledge, skills and attitudes to communicate effectively with dying patients. And at St Vincent's, we wanted to explore what dying looks like in our acute hospital and then what we could do to improve it, if it wasn't good to start with. So St Vincent's participated in a multi-centre study, and this was coordinated by the Australian Commission on Safety and Quality in Healthcare. And thanks to Professor Imogen Mitchell from the ANU, I think she's next door, who drove the pilot study in Canberra and was the primary investigator for this study. So we had two phases of data collection. The first involved reviewing 201 medical records of St Vincent's acute care patients, and these were randomly selected by a biostatistician. So as I said, these records were reviewed, and they were reviewed retrospectively by clinical staff, which involved medical staff, doctors, and a nurse with an intensive care background. The second phase of data collection was an online questionnaire, and this was distributed to all relevant clinical staff and collected information on the perceptions and experiences of healthcare professionals involved in delivering end-of-life care in the acute setting. So with these both modes of data collection, this allowed the staff context within the findings. So what did we find? So of the 201 patient records that were reviewed, we had 59% were male. I'm not sure what that says about the male population dying. We had an overwhelming majority, with 78%, were over the age of 60 when they died during an acute admission, and 69% were classified as medical patients. We weren't really surprised about this result because as we're a metro hospital surrounded by trauma hospitals, we sort of were expected to see most medical admissions. However, 71% of the patients that died did come from home, and we did find this unexpected. And perhaps the lower percentage of deaths from patients from a residential aged care facility could be attributed to end-of-life care being delivered in those facilities, rather than the patient being transferred to a hospital. And initiatives like Resident InReach may assist with this. Interestingly, 60% of audited deaths had multiple prior admissions in the past 12 months, and 30% had no prior admissions in the past 12 months. However, a limitation of the study is that we could only audit prior admissions at St Vincent's, so it is possible that the patient did have prior admissions elsewhere that were unknown to us. So when we looked at resuscitation plans, over 92% of patients had a resuscitation plan documented during their admission. However, our data reflects the uncertainty of who is responsible for completing these forms at our hospital, with 30% completed by the home team junior doctor and 28% completed by the admitting registrar. And our policy at St Vincent's does not mandate compulsory completion of these forms, and I guess the culture of whose responsibility it is unclear, although generally the responsibility falls to the home team. And we do also see more resus plans completed by ICU staff than our ED staff. So as you can see that the processes around resuscitation plans at St Vincent's can be somewhat ad hoc. 21% of patients that had a rapid response review during their admission, and of these 23% died during this review. So these cases demonstrated very late recognition of dying. Revised resuscitation plans were documented during or immediately after rapid response review in 30% of patients. We all know that rapid response teams are sometimes utilised for end-of-life care, and this is also reflected in our data. So of the 92% of patients with a resuscitation plan, 42% of these had their resuscitation plan revised to a less aggressive approach at any time during their admission. And one data point that we found really interesting was the time between documentation of the first resuscitation plan to the time of death, and this was a median of 1 day. So this suggests very late recognition of dying, or also possible avoidance of completing resuscitation plans. So I guess in summary, our data around resuscitation plans demonstrates the late recognition of dying and therefore areas for us to improve. There was documentation to suggest that the patient was dying in 83% of patient records, and furthermore there was documentation that this was communicated to the patient and or their family in 86% of the records. However, the median difference between the documentation of the patient dying and the time of death was 0.84 days, so less than 1 day. And this correlates with the documentation of resuscitation plans, which was also on average 1 day before death. So overall, 66% of patients had an intervention in the last 48 hours of life. So blood tests, IV fluids and IV antis were the most frequently provided interventions in the last 48 hours of life. And these results were also echoed in the other 9 hospitals that also participated in this study. So when we looked at palliative care or comfort care plan, and by this we mean symptom management only, 70% of the patients audited had one at any time during their admission. However, the duration of the time that a patient received comfort care prior to death was very short, with a median of 0.6 days. So this, along with the documentation of resus plans, which is about 1 day, and communication of dying to the patients or their families, which was less than 1 day, are all suggestive of very late recognition of dying. And in total, 48% of patients were referred to specialist palliative care during their admission. So less than half of the audited patients did not have a referral to palliative care. But maybe not every patient does need a referral to palliative care. And at St Vincent's, we do have a large and visible palliative care consult service that generally can see patients within 24 hours. And these results up here on the screen are also echoed in the other hospitals that also participated. So when we look at the survey results from our clinicians, the survey was completed by 263 nurses, 72 specialists, 41 junior doctors and 38 allied health staff. And the response rate was roughly around 15%. However, this is difficult to determine due to the denominator of classifications of clinical roles. However, the reported data still provided us with some interesting themes to interpret the results, as we'll see as we go through. So 97% of specialists, 85% of junior doctors, 90% of nurses and 63% of allied health staff were confident in their ability to recognise when a patient is dying. So So by self-report, all clinical staff know and feel comfortable in recognising dying patients. However, only 37% of nurses and 44% of specialists thought that junior doctors on their ward were skilled at recognising a dying patient. So there was a real difference of views here. Conversely, 85% of junior doctors and 92% of nurses thought that senior nurses on their ward were skilled at recognising when a patient is dying, so the views here were more aligned. And these views reflect the capability of our senior nursing staff to recognise dying patients. So 81% of junior doctors and 99% of specialists believe that they were skilled at talking about death and dying with their patients and families. However, only 67% of nurses felt they were confident in their ability to talk about death and dying with patients and their families. So this is an area of improvement for us perhaps. But given that senior nurses are acknowledged to have the ability to recognise dying patients, perhaps we need to upskill the communication skills of our senior nurses more so. There was once again a difference of opinion, with 81% of junior staff, of junior doctors, thought that they were skilled about talking about death and dying with patients, whereas only 35% of nurses thought that junior doctors on their ward were skilled at talking about death and dying with patients and families. So these views were not aligned. So I guess sometimes we see ourselves differently to how others view us. So the findings of this order are consistent with existing research showing that clinicians do recognise dying, but this often occurs very close to the patient's death. And although a significant proportion of patients die in hospitals, most healthcare professionals have limited formal training about end-of-life care, and consequently, as this has been shown in our study, there is a tendency towards continued interventions and treatments in the last days of life. This study also showed that amongst patients who had a rapid response review, almost 1/3 had a revised resuscitation plan, and rapid response reviews may not be the optimal time to discuss goals of care and resuscitation status, as the team may have limited knowledge of the patient's circumstances and also have limited rapport with the patient and the family. So senior nurses can also be skilled in recognising when patients are dying, and indeed this study showed that the majority of junior doctors and nurses believed senior nurses on their ward were skilled at recognising a dying patient. Hence, senior nurses could assist junior doctors to escalate the management of patients to more senior clinicians if they believed the patient was deteriorating and was receiving inappropriate treatment on the ward. Strengths of this study were that it provided a baseline data for our end-of-life care working group at St Vincent's and would allow comparison across sites. Potential limitations of this study include the retrospective auditing of medical records that may not accurately reflect the provision of care that was provided. It is possible that the recognition of dying and discussions with patients and their families occurred earlier or more frequently than it was actually documented. And with regards to the health professional questionnaire, there could have been a response bias because the questionnaire was voluntary. So since the audit, the end-of-life care working group at St Vincent's has adapted the care plan of the dying person from the Victorian End-of-Life Care Coordinating Program in consultation with the best care of the dying person. We've implemented this care plan of the dying person in palliative care and a few other wards at St Vincent's, and we are continuing the rollout and implementation across the hospital. So integrated care plans for the dying are best practice and recommended approach for hospitals to guide and support the delivery of consistent, high quality and best practice care. However, it is only a tool and can't replace clinical judgment, and it can't replace communication between the treating team and the patient and family. So the purpose for us using this tool is to standardise the care we deliver to dying patients across our health service. So the End-of-Life Care Working Group at St Vincent's spent time reviewing our data, and the take-home messages for us where there needs to be greater timely recognition of the dying patient. This may be partially achieved through our education around the care plan of the dying person and dissemination of our findings from this study. We need to empower all clinical staff to ask the question, could this be dying? And in particular encourage senior nurses to speak up and be heard when they recognise dying patients. And teamwork is also vital for providing quality end-of-life care. This study also demonstrates the need for further communication skills around talking to patients and families, and this is especially needed for senior nurses and also junior doctors. So the End-of-Life Care Working Group continues to raise awareness around the dying patient at St Vincent's and is working towards implementing the end-of-life care criteria from the new Comprehensive Care Standard in version 2 of the National Standards to improve end-of-life care at St Vincent's. And lastly, I'd like to thank my colleagues at St Vincent's who did this study with me. Thank you.